Hi guys, picking up where we left off, let's talk about the physics of blood flow through the cardiovascular system. And then we will see which of the actual arteries and veins names that you will need to know, okay? So starting out with some physics of cardiovascular circulation here. Some key terms for starters, okay? Blood flow is usually measured in mils per minute, milliliters per minute. It's equal to and interchangeable with the cardiac output. Okay, so it's literally the amount of blood that your heart is able to pump per minute. Okay, in milliliters. CO will be cardiac output, which will also mean blood flow. This, of course, varies in different organs, right? So just like we learned, capillary beds and the arterioles that control the blood flow to them are closely controlled by the autonomic nervous system. Some capillary beds will be shut off due to those pre-capillary sphincters. Therefore, certain organs will have a less blood flow, a less cardiac output. They won't get as much of that blood that the heart is actually pumping out. But other areas of the body will. So the net cardiac output, the net CO, remains the same. Blood pressure is measured in millimeters of mercury. That's the way it is. Okay, so millimeters, Hg, is millimeters of mercury. So it's the amount of force on a unit of area, a little unit of area of the vessel contained by the contained blood. Okay, so the blood passing through the vessel exerts pressure on the inside of the vessel. That is blood pressure. That is what we feel when we take a pulse. Okay, that is what we measure when we're doing a blood pressure cuff. The pressure of the blood on the vessels, which is directly related to the cardiac output, right? Resistance is the opposition to smooth blood flow. Okay, so the amount of blood and the speed at which the blood is able to flow depends on how much resistance or how much friction it encounters as it's traveling through your blood vessels. Okay, there are various forms of resistance. There are different ways that different things that can oppose blood flow through the system. Blood viscosity, the thickness of the blood, okay, which is depends on how much water is in it, right? A more viscous fluid is less watery. So we control our hydration in a lot of different ways. The kidneys mainly, but like we saw, we can filtrate or filter out and then reabsorb a certain amount of water. So water is going to end up in the interstitial tissues. It's going to end up in your urine, right? You're going to pee it out, and that is going to contribute to blood thickness. The blood vessel length. So the length of the vessel is going to determine how much resistance it poses to the flow of blood. Much longer vessels are going to impose more friction or more resistance to that blood flow. And then the diameter of the blood vessel is also going to contribute to how much opposition it poses to blood flow. A big, wide vessel with a large diameter is going to have less resistance or offer less resistance to blood flow than a very narrow vessel. Consider a milkshake and how you best drink it through a straw. You want to drink a milkshake, which is very, very viscous, high viscosity, very thick, through a short, fat straw, right? You want it to have a nice wide diameter and you want it to be shorter. Trying to drink a shake through a long, skinny straw is very, very, very difficult. There's a lot of resistance. There's a lot of friction. There's a lot of opposition to flow. Okay, so shorter vessels, wider vessels, those are going to decrease resistance, as well as a more watery, less viscous blood is going to also keep resistance low. The total resistance of your cardiovascular system, of your vascular system to blood flow is referred to as the total peripheral resistance. So the TPR is the resistance that your blood flow is encountering, and it is the combination of the blood flow and the resistance that causes the pressure of the fluid inside of the vessels, excuse me. That pressure inside of the vessels is your blood pressure. And there you go. A couple of things here. Flow resistance, getting a little bit more physicsy here. If you have a branching vessel, usually an artery, it's going to have to be an artery because we're talking about pressure, right? So we're talking about arteries. The pressure of blood is being forced by the heart through the arteries. By the time it gets to the capillaries and the veins, like we talked about in our last lecture, there isn't as much pressure there. So we're talking about arteries, really. So if you have a branched artery here, you have 4 liters of blood traveling through this system per minute. Even if you were to constrict one and increase resistance by however much that is on vessel B right there, you constrict it, you have a narrower tube with a smaller diameter, therefore you're going to have less blood flow, but the speed of blood flow and the amount of blood flow through the other vessels will pick up and make up for that, okay? The pressure in all of these vessels will go up, but the blood flow will remain the same. You will still add up to 4 liters per minute. The total flow remains unchanged. What changed was the resistance and therefore the blood pressure in the system. Okay, so if there's no restriction, then all vessel flow is generally equal if the vessels are the same size and length. But if one vessel constricts, the blood flow increases in the parallel vessels to make up for it. This is just physics stuff. It's not really even anatomy stuff. It's not even biology stuff, really. This is physics stuff, okay? That's just how that works. The control of blood flow through your body. So we already talked about how the autonomic nervous system controls a lot of this, right? It controls the arterioles and those precapillary sphincters, that smooth muscle, right? And the smooth muscle in your muscular and elastic arteries as well. So blood flow varies between organs depending on their needs. This is reiterating what I talked about in the last lecture, basically. But if you are talking about your sympathetic nervous system being active, right? You are at 100% of cardiac output is going to be 5 liters per minute here. You're going to have most of that. Actually, in this case, we're probably talking about the parasympathetic nervous system. We're talking about rest and digest because check it out. Your liver and digestive tract are getting a relatively large proportion here. Your brain, your heart is getting a little bit less. Your kidneys are getting a lot. Your skeletal muscle are getting a lot, which is usually a sympathetic nervous system thing. So maybe this is a kind of an in-between, but relatively speaking, your different body systems and your different body organs are going to be receiving a different proportion of blood based on how much they need and how much they are needed in that moment, depending on whether more of your parasympathetic nervous system or your sympathetic nervous system is active. Okay, so the blood flow through different organs of your body is not equal. And it changes all the time, right? Okay, so blood flow and blood pressure here. We already talked about systolic and diastolic pressure, right? So the systolic, again, is ventricular contraction. Diastolic is ventricular relaxation, okay? So the systolic number in a blood pressure reading is usually the higher number, or it should be the higher number, right? Because that's the higher pressure when the ventricle is contracting. And then the diastolic number is going to be the lower number on the bottom because that's the pressure that's still there when the ventricles are relaxing. The pulse pressure is the blood pressure that you can feel from a artery near the surface of your body. It is technically, in a physics sense, known, it's the difference between the systolic and the diastolic pressure, which is also known as the mean arterial pressure. Since we only take blood pressure, we only take pulse pressure from arteries, it makes sense that it would be called the mean arterial pressure. What doesn't make sense about it is that the mean is usually the average of something, but in this case, the mean arterial pressure is actually the diastolic pressure plus about 1/3 of the systolic pressure. You don't have to know this formula. It's just in case you were wondering, it's not right in the middle. You can see in this chart that the mean pressure is a little bit lower than what it would be if it was actually like dead centering between the systolic and the diastolic pressure. So it's diastolic plus 1/3 of systolic, okay? So also note in this chart, very important, we're looking at blood pressure on the y-axis and the different blood vessels in order from the heart back to the heart. So from the aorta on the left through arteries, arterioles, capillaries, venules, veins, and the vena cavae. You'll notice that both the systolic and the diastolic blood pressure, and therefore the mean arterial pressure, is going to go from being up here. This is going to be a normal blood pressure, would be systolic over diastolic 120/80. Okay, so a 120 millimeters of mercury at a systolic pressure, so at the highest pressure, and an 80 millimeters of mercury of pressure for the diastolic pressure when the ventricles are relaxing, leading to whatever this is, 95 MAP, an MAP, a mean arterial pressure of about 95. All up here when you're in the aorta. Still pretty high when you're in the arteries, starting to drop off when you get into the arterioles, dropping off almost to minuscule amounts in the capillaries, and then dropping off to really nothing almost by the time you get into the venules, veins, and the vena cavae. Okay, so what's important here is that we're noticing that the blood pressure is very high in the elastic arteries, and then it drops off from there, okay? And then it drops off to nothing really by the time it gets back to the superior and inferior vena cavae. Okay, same wordage over here, just a different chart showing you how the pressure along with time of systolic and diastolic pressures looks. Okay, so this is a little bit different than like the ECG, the EKG that we looked at last week. Your diastolic pressure down here at 80, systolic pressure up here at 120. A little dip here when your aortic valve closes. The mean pressure is maintained. So that mean arterial pressure is the same across time during a heartbeat of blood pressure reaching systole and then diastole. The mean stays the same. This is down below, still pressure on the y-axis, but we're looking at age now on the x-axis instead of time. So as you get older, that pressure, that mean arterial pressure actually increases, gets higher and may taper off, but it gets higher because your blood vessels become less stretchy. So that pressure is more strongly felt in the vessels because they can't stretch as much. So you have more pressure pushing against the walls because the walls aren't giving, right? Systolic pressure, systolic blood pressure will slowly rise, therefore, as you get older because of this, right? And diastolic pressure will rise and then it might actually start to fall there. So yeah, some interesting like age-related consequences to blood pressure and blood flow there. All right, so this is kind of showing you the same thing as that other graph. From the left ventricle to the right atrium, blood pressure in millimeters mercury is highest, of course, in the left ventricle. By the time you get into the arteries, it is lower, and this is what we actually measure, right? With our blood pressure cuff. Systolic is the high mark, diastolic is the low mark. Mean arterial pressure is not quite in the middle because it is diastolic pressure plus 1/3 of systolic pressure, technically. This region here in the arteries, the muscular arteries, namely, Usually when we're taking blood pressure from here, we're taking blood pressure from the brachial artery, which is a muscular artery. This area is where we're going to feel pulse pressure, okay? It's also where you're going to feel pulse. That's where you're going to be able to, that's how you're going to be able to measure blood pressure, by using that pulse, okay? So that mean arterial pressure, again, will drop off as we move from the arterioles into the capillaries, and then back up through the venules veins to the right atrium. Blood pressure drops down to nothing. So the pressure is at its highest at the left ventricle. It is the systolic and diastolic difference is greatest at the aorta, okay? And then the systolic and diastolic pressure is that difference between the systolic and diastolic, this wavy pattern, goes away by the time you get into the capillaries, smooths out. Okay, so you would not be able to determine a pulse because you do not have this blood pressure rise and fall, which is what a pulse actually is. You would not be able to measure that in capillaries or any of your veins. All right, so your pulse can be measured from various arteries, muscular arteries throughout the body. These include the facial artery here, the superficial temporal artery here, the carotid artery down here. Of course, your brachial artery, which is going to be found here. The brachial muscle, remember, is right here, so your brachial artery here. Your radial artery is the most common one. It's very simple. You take your index and your middle finger. You don't want to use your thumb. Usually you can feel it, but there's a chance that you might be feeling your own pulse. The vessels here might be large enough that you might be able to detect your own pulse if you do that. So it's safer to use your first two fingers right under your thumb, right at that distal end of your radius. You should be able to feel your pulse right there. You also are able to feel a pulse at the femoral artery, which is right at the groin, the popliteal artery, which is the back of your knee, the posterior tibial artery, which is at your ankle, and the dorsalis pedis artery, which is at the top of your foot. These pulse points can be used if you are pressing the artery closed or nearly closed over a firm tissue, right? So that's why these are so useful, is because there's something a little bit firm on the, behind it, so that you can kind of squish the artery up against that firm tissue, and that's how you can feel the pulse, that blood pressure trying to get through. Pulse points are also known as pressure points because in the case of a severe hemorrhage, these are places where you can stop the blood flow. Okay, so if you have blood flow on the face or head or neck, you're going to want to stop that here at the carotid artery. Okay, you're going to want to pinch that artery. If you have a injury and hemorrhage from the lower arm, you're going to want to put a tourniquet on at or above the brachial artery. That's where that blood flow needs to be stopped. An injury to the leg, catastrophic injury to the leg, may require the femoral artery to be pressed closed. The lower down the leg, the popliteal artery might be enough for that. I guess if you had, if you lost a toe, you could use these. But if you know where the arteries are, right, those are what you're going to want to try to keep closed to prevent blood loss, right? Because as long as blood is flowing out of those arteries, it's leaving the body entirely. If blood is leaving through the veins, you want to stop that too. But since one, you don't have the low blood pressure, and two, it's not the oxygenated blood returning or trying to get to your body, you end up with a little bit more time anyway. Not much, but arteries are really, really dangerous if you sever them. And they will save your life if you know where they are and can apply a tourniquet in case of a catastrophic injury and hemorrhage. Okay. The average resting pulse for a person is about 60 beats per minute. It's okay if yours is a little bit higher or lower. I know that anxious people tend to have a higher one, and people who exercise a lot tend to have a lower one. Because if you're increasing your heart rate, you're increasing the stamina of your heart. If you exercise, Therefore, when you're at rest, your heart is so strong that it doesn't have to work as hard when you're resting, right? The sympathetic nervous system can increase your heart rate and your pulse rate to 180 beats per minute, or higher in some cases, but obviously getting pretty dangerous there. But that's really, really fast. That's pretty amazing. So your sympathetic nervous system, again, if it had full reign, then you would have super fast heart rate all the time. We need to make sure that we have the parasympathetic nervous system to balance that out and kind of remind your heart to chill, right? Very important. Okay, so let's learn how we actually take blood pressure measurements using a blood pressure cuff, also known as a sphygmomanometer. A sphygmomanometer. Sphygmomanometer. There it is. Sphygmomanometer. You have to make sure that you get the right emphasis on the right syllable, right? The sphygmomanometer is the fancy name for the blood pressure cuff. You apply it above the brachial artery, okay? So you have this branch here. So this is the brachial artery right here. It branches into the radial artery and the ulnar artery. So you want to apply the blood pressure cuff above the elbow where you get that nice muscular artery, that brachial artery. You're going to increase the pressure in the cuff, okay? So you're going to inflate the cuff, which is going to squeeze the arm until it literally squeezes that brachial artery closed entirely. And when that brachial artery is closed entirely, you will not feel a pulse because there is no blood coming through. You don't leave it like that, and you don't measure a blood pulse at this point. What you do is you slowly release the pressure, and usually it's by spinning this little guy right here. You slowly release the air out of the cuff, which slowly releases the pressure. As soon as there's enough of a gap for blood to pass through the artery again, you will hear a loud pulse through your stethoscope where you are listening here in the crook of the elbow at that brachial artery on the other side of the cuff, right? The blood is flowing from up here to down here. We cut it off with the cuff for half a second. Then we slowly let the cuff deflate and listen. The moment that we hear blood starting to pass through, the pressure indicated by the gauge is showing you the systolic blood pressure, the big number on top. You continue to let air out, and the moment that you stop hearing a pulse at this point, because you're not putting pressure on it anymore, wherever the indicator, wherever the needle is on the pressure gauge at that moment is the diastolic blood pressure, the smaller number at the bottom. A normal blood pressure for an adult would be 120/80, okay? Higher than 120 is considered to be hypertensive. Lower than 80 is considered to be hypotensive. Hypertension is much more dangerous, generally speaking, than hypotension. Hypotension doesn't usually tend to hurt anybody unless you like literally have hypothyroidism or something, which is relatively rare. But hypertension is really, really common, and having a constantly elevated blood pressure is really, really hard on your blood vessels, especially your little capillaries. So remember your little capillaries with their single cell epithelial cell walls, very, very thin, very, very small, and very easy to break. So if you have high blood pressure all the time, you're putting too much pressure on your capillaries all the time, and they can break, which is, of course, very bad. We do not want that. So you measure your blood pressure or a patient's blood pressure like that. It's pretty cool. All right, how does the autonomic nervous system control these things? We already pretty much talked about this when we talked about the heart and some of the autonomic nervous system control of the heart. But basically, from the brain stem, you have both parasympathetic and sympathetic control over the SA node of the heart, right? That is going to control how fast the heart is beating, right? That controls the rhythm of the heart. You also, which is going to control how fast the rhythm of the ventricle contractions, right? At the same time, Your sympathetic nervous system is also going to have control over your veins and arterioles, namely their how constricted or dilated they are. So vasoconstriction is making the vessel smaller, and vasodilation is making a vessel larger, dilating the vessel, right? Usually it's your sympathetic nervous system that's going to cause your blood vessels to constrict, which is going to increase the blood pressure. It's going to increase the blood flow. Your heart is going to usually speed up at the same time if your sympathetic nervous system is at play here. The pressure in your carotid and aortic arteries is being constantly monitored by sensory receptors known as baroreceptors, right? So remember, there are different types of sensory receptors. These are autonomic, of course, right? These are monitoring the pressure in these vessels. If it gets too high, it's going to trigger a negative feedback loop, which is a domino effect of processes that is going to result in a lowering of the blood pressure as much as can be, right? So this is kind of an indicator. This is kind of showing you this negative feedback loop. Okay, so here's a little chart of this negative feedback loop. We already talked about negative feedback loops in part A, and we used blood pressure as an example. At least I did if you took my class, but it's a pretty classic example. If blood pressure goes up, those baroreceptors in the aorta and the carotid arteries are going to be triggered. They will send the signal up sensory neurons to the medulla oblongata. So the brain, right? The central nervous system. It's going to then kind of cut out the sympathetic part. So basically, you're going to decrease the action of the sympathetic output of the sympathetic nervous system. So that means that less of its neurotransmitter, which is norepinephrine, is going to be released. As a result of that, you will have the smooth muscle of your arteries relax. So you have vasodilation, right? We're trying to cut out the sympathetic nervous system, right? Blood pressure has gone up. So we're trying to say, calm down. We're going to increase the action of the parasympathetic nervous system, which means more acetylcholine, which is its neurotransmitter. This is going to result in the SA node lowering the rate of the heartbeat. So we're going to slow down the rhythm of the heart. That the less norepinephrine that gets released means that the ventricles of the heart are going to decrease the force of their contraction. And the SA node is going to decrease heart rate, as does the increase in acetylcholine. So the force of contraction is going to go down, the heart rate is going to go down, vasodilation will go up. Therefore, resistance, peripheral resistance, total peripheral resistance, if you will go down because the vessels are now wider, larger diameter, right? Cardiac output will go down because the heart rate is slowing, and blood pressure will go down. Once blood pressure has gone down enough, the baroreceptors in the aorta and the carotid arteries stop being triggered. Once they stop being triggered, the medulla stops getting that signal, okay? The brainstem stops getting a signal to lower blood pressure. The system cuts itself off. Negative feedback. Pretty cool. Oh, I made this beautiful Venn diagram for you. What do you think? So your arteries carry oxygenated blood, of course, right? Except for your pulmonary arteries, which carry deoxygenated blood. Your veins carry deoxygenated blood, except for your your veins carry deoxygenated blood except for your pulmonary veins, right? Your arteries carry oxygenated blood except for your pulmonary arteries, right? So don't get caught up in this red and blue arteries veins thing, because it's not always true. Red is oxygenated, blue is deoxygenated. Arteries carry blood away from the heart, veins carry blood to the heart, okay? because there are these exceptions for the deoxygenated and oxygenated blood flow through arteries and veins. The pulmonary circuit is backwards, okay? Your arteries tend to run deep. This is by design. It's very important, right? Arteries get cut, you bleed to death. So the arteries are deeper in your body to protect them. Your veins can be deep, but they can also be superficial. They are the ones that you can like see on the surface of your skin, right? So your veins are the ones that they may look blue under the surface, but that's not because your blood is blue, okay? They look blue or green or maybe purple on the surface depending on your skin color. It's the combination of the dark red of deoxygenated blood and the color of your skin that makes them appear blue or green or whatever. So it depends on how much like of that carotene pigment is in your skin, and of course how much melanin is in your skin. Yeah, that's what makes your veins like kind of look blue or greenish under your skin, but that doesn't mean that the blood is blue, okay? Your blood is dark red when it's deoxygenated, and it's bright red when it's oxygenated. You may notice that difference if you ever see blood in real life, which hopefully you will if you're going to be nurses, right? Okay, so your arteries run deep. The veins that run deep, which are going to be mostly the ones that we're going to be looking at today, are going to run along with the arteries, which is really nice. They're often also called the same thing, so they have the same name, okay? So it's usually the main artery and the main vein, and they are hanging out together, and one's taking blood in one direction and the other's taking blood in the other direction. And they also tend to run along a nerve too, which is kind of cute. So the nervous system develops and the nerves spread out, right? And then each neuron talks to each other as they, as you grow as an embryo, and then as a fetus. And your blood vessels kind of follow the nerves. So you might see, actually we will see, if you look at this, how the nervous system and the vascular system kind of hang out together in a lot of respects. And even more so if I were to add all the layers here, which is actually kind of scary. So, but I gotta do it now. Woo! So look at this guy now. Oh, that's totally creepy. Look at how creepy. Anyway, so this is your arteries, your veins, and your nerves all put together. And a lot of them travel along the same tracks. And they may even be named similarly as well, depending on if they're named for the structures that they're around or the regions that they're in, right? Okay, I'm gonna take off this, the nervous system, one, because it's creepy, and two, because we're not talking about it right now. All right. Your superficial veins get their own names, which is annoying, but we're not learning a lot of those right now, so don't worry about it too much. Your venous pathways are also more interconnected. So they, while your arteries tend to branch and branch and branch, your veins will converge and converge, but they'll actually, sometimes they'll converge earlier and then you get kind of a web effect. So your veins can be a little bit more complicated to learn than the arteries. But in this class, we're kind of just going to be learning about the parallel arteries and veins and not looking too much at superficial veins or any of the really complex venous pathways. All right, so your arteries and your veins in the middle here often run with nerves. They are often named by the body region that they're going through, the organ that they serve, or the bone that they are following. And they're not always symmetrical, okay? So your arteries and your veins, sometimes you've got something going on the right side that's not going on the left side. So they're not perfectly symmetrical all the time. Lots of them are, but as we'll see, not all of them. Okay, deep breath. We're gonna start talking about which ones you need to actually know now, okay? This is systemic. We're not talking about pulmonary here. Next week, we'll talk about pulmonary since we're going to be talking about the respiratory system. Okay, so this is all systemic stuff that we're talking about here, okay? Which is why the arteries and the, this is why our schematic here is in red because this is systemic, therefore this is oxygenated stuff. Okay, systemic arteries do carry oxygenated blood. Okay. All right, so these schematics are in your textbook. They are awesome. I love them. I think they're the coolest thing I may have ever seen, actually. They're just so cool. Okay, so check out your textbook. This is page 738 and 739. We have a schematic to go with each part of the body. And the schematics are so cool because they really simplify. I know it doesn't look like it here, but this is the entire body. Okay, so this is the major arteries of the entire body here. The heart is here. Okay, so your heart, turn on the pen, is here. Okay, there's your heart. There's the left ventricle, the ascending aorta, the aortic arch. We're going to learn that. We're going to learn about the descending aorta. We're going to learn about the brachiocephalic artery, the left carotid, and the left subclavian. And we're going to learn briefly and simplistically what those things branch into, which is roughly the right carotid in the case of the brachiocephalic, and the subclavian, which becomes the axillary, which branches into the right radial and ulnar arteries. The middle, remember the aorta goes up and over the heart, and you've got those 3 tubes, right, in a human. Remember, we saw these last week. This one is this brachiocephalic artery or trunk. This one is becomes the left carotid, and this one is the left subclavian, becomes the left subclavian. Okay. Then the same thing happens over here with the subclavian becoming the axillary, becoming the brachial, becoming the radial and ulnar. Going up the head through the right and left carotids, you get up into a really cool structure called the circle of Willis, which is in the middle of the brain. And really cool, we're gonna take a look at that in a minute. Going down the descending aorta, as we continue down to the rest of the body, the aorta becomes the abdominal aorta. After it, do we do this? Not really. The abdominal aorta, by the time we get down here, further down, past the diaphragm, below the diaphragm, we're going to have what's called we're going to have a branch called the celiac trunk. That's really the only one that I want you to know here, except for the what happened to the kidney? Oh, the phrenics. Nope. Not mesenterics. Oh, renal. We also want renal, which is your kidneys. And then it continues down and splits to go down each of your legs, right? And when it first splits, we call it the common iliac, then the external iliac, then we get down into the femoral and the tibial and the fibular arteries, okay? So this represents the entire body. Let's break it down a little bit further, and I will underline the ones that you need to know. These will be the ones that are on the study guide and the ones that will be on the list that I have for your lab, in your lab description right now, okay? So make sure that you print that out or write it down or have it somewhere, because you're going to want to check these off as we look at them in person in the Rabbit on Thursday. Okay, bring this list with you. You will need to know, and I'm going to underline them on each of these slides. We're going to look at them multiple times, okay? So don't panic here. From the heart, you need to know the ascending aorta, the aortic arch, the brachiocephalic trunk, to the subclavian artery. You need to know your common carotid arteries. You need to know your external and internal carotid arteries. These branch from the common. So you have common, and then you're going to have internal and external. You will see this pattern again. Going down the arm, on each side, this is the same thing on both sides. You're going to have your subclavian artery to your axillary, to your brachial, which branches into the radial and the ulnar. Your abdominal aorta is what we call it after it goes past the diaphragm. The first branch will be the celiac trunk. That is going to go and feed a lot of important structures of the digestive system, but we're not going to be interested in which arteries those are necessarily. We want to know about the renal arteries. And then finally, we get down to this branching here, down to the each branching down to into each of the two legs. After the branch, we call it the common iliac artery. We have a little branch happening here, in which we have the internal and the external iliac arteries. The external iliac artery continues down and becomes the femoral artery, which becomes the popliteal artery, which then branches into the anterior and posterior tibial artery, as well as the fibular artery, okay? So each of these structures is named for its location, the structures that it serves, the structures that it's bringing blood to, or the bones that it is traveling along with. Okay, so a lot of these words you have heard before, and you could probably deduce the name of the artery based on where it is in the body if you had to on an exam. I don't recommend it. I'd rather you actually learn it, but you can kind of sort it out on your own. So this is the schematic for the arteries of the head and neck. So basically going up here, we're starting down here, okay? So these are those three branches of the aorta. Here's the aortic arch. Here's 1, 2, and 3 branches of the aorta, okay? Those 3 trunks that come out of the top of the aorta. The brachiocephalic trunk is the first one, again, right? This one we need to know. It is going to branch off and become the left common carotid artery, and then the subclavian, which means below the clavicle, subclavian, okay? So you have the brachiocephalic trunk branching off into the left carotid and the left subclavian, okay? And, oh, this is where that's going. Okay, this is the common carotid. That middle branch coming off of the aorta, the middle one, that comes up directly and becomes the right carotid, the right common carotid, okay, by itself. That's all it does. There it goes. And then the third one on the aortic arch, that last trunk, that is going to go off and become that, the subclavian, the left subclavian. Did I get this mixed up? I think I got it. I think I've been watching myself on the camera. So this is always the patient's left and right, okay? So sorry if I got that weird. So this would be the right side with the brachiocephalic trunk, the right the left carotid and the left subclavian. So this is the left carotid, left subclavian. This goes to the right subclavian. This is the right carotid. Okay, so your right and left carotid arteries, common carotid arteries, they are going to go up either side of the neck. They are going to split, and you will have an external and an internal carotid artery, okay? Here's the internal branches here and here. These are the external branches here and here. The external branches will come around and they will meet with this structure right here, which is the cerebral arterial circle, also known as the circle of Willis, which is right in the middle of your brain. It's like a halo in the middle of your head. Really weird, really cool. And here is that circle of Willis here in a little bit more realistic context. And again, here is the right side of this patient, this person, right? So here's the aortic arch. You've got the brachiocephalic trunk, the subclavian coming up and around here, forming the axillary artery. So the subclavian and axillary. Axillary means armpit, right? So the subclavian goes under the clavicle, subclavian, and becomes the axillary as it passes through the armpit. After it's the axillary, it comes down and becomes the brachial. Okay. We need to know the common carotid. This would be the right? And then the external and internal carotid arteries. So where it branches here and here. And this whole deal. Do you have a thing? Here we go. The cerebral arterial circle, AKA the circle of Willis. Let's pause and explore our little friend here. I'm going to zoom in if I can. That seems to be the hardest thing to do. I'm going to turn off the venous layers here. So I'm going to remove all the veins so we just have arteries. And then I'm going to remove a lot of the arteries. There. This is really what you need to know. Okay, so notice that I've removed a lot and have mercy on me. So here's our aortic, ascending aorta, aortic arch. Here is our brachiocephalic trunk branching into the right common carotid and the right subclavian. The center trunk here goes straight up to become the left common carotid. And the third trunk comes up and over to just become the left subclavian, okay? That brachiocephalic trunk that became the right carotid and the right subclavian, let's follow this right carotid. And remember that the left carotid is coming straight out of that middle trunk, okay? So this is what I mean by not symmetrical. So this is one of those examples where the arteries aren't really that symmetrical. You've got one trunk here that branches into the carotid and the subclavian, while the carotid and the subclavian are separate coming out of the aorta on the left-hand side. Kind of weird, right? But check out how your carotids come up the neck and then they branch into the external. Let's see if I can capture this here. And the internal. External, internal. Okay, from that common carotid. Oops. Don't mind that sinus. Okay. And if we follow these up, they will become part of that circle of Willis, which is, we can only see partially here because I've removed the rest. Okay. But the circle of Willis is here. We're just missing some parts of it. Oof, and it gets too complicated here to really see it that well. Right here. Okay. So trust me, it's there. Okay. the center, in the middle of your head. Okay. Let's see if we can, there we go. All right, let's continue by looking at how the blood vessels travel down your arms, okay? Here's the schematic for it. It looks very complicated. I'm not asking you to know all of it. This is your aortic arch again, your brachiocephalic trunk, your right common carotid, your left common carotid, and your left subclavian. This right subclavian comes down and becomes the axillary, the right axillary, which continues down to become the brachial, which branches to become the radial and the ulnar artery of the right-hand side. The left-hand side is exactly the same, okay? So going in this direction, it looks exactly the same, okay? Let's take a look on an actual human-looking thing. Here's our aortic arch, brachiocephalic trunk, the right common carotid, the right subclavian coming off of that brachiocephalic trunk, the middle trunk coming up off of the aorta is the left common carotid. Oh, I guess we're including both right here. And that last one becomes the left subclavian, okay? We follow the subclavian all the way. We'll follow the right one since we have an arm over here to follow. It will become the axillary artery. And as it continues down, it becomes the brachial artery. And as it continues down, it branches, becoming the radial artery and the ulnar artery. Now let's take a look on this guy. Okay. You guys still with me? Okay, so here's our brachiocephalic trunk. And over here we've got which is going to become, it branches, right, to become the right subclavian over here. The left subclavian comes directly out of the aorta over here, but from there on out, they're the same. You have your axillary on the right, axillary on the left, becomes the brachial on the right, and the brachial on the left. At this point, we're talking about muscular arteries here. And then those brachial arteries are going to branch into the radial and ulnar. I can snag it here. Too far. Ulnar. Radial and ulnar. Okay? Not that bad. It's really not that bad, right? Okay. Now we're going to follow the aorta down past those branches. Okay, so we're going to go past these branches and follow it down the descending aorta. Check out the blood vessel pattern here at the diaphragm. You can tell that the diaphragm is here based on that pattern, which is pretty beautiful. It's pretty awesome. I love like blood vessel patterns. I just think it's so cool. Okay, excuse me again. Okay, so we're gonna follow this descending aorta, which goes down behind, posterior to the heart, and inferior down here. Okay, here's the schematic for everything under the diaphragm, down to basically the split before we get to the legs. Okay, so this is the abdominal aorta, this whole thing, all the way down. Okay, we do wanna know about the celiac trunk. Okay, so this branch right here. We also want to know about the renal arteries right here. Since we're going to be talking about the urinary system, that's important. These are going to go to your left and right kidneys. Super duper important, right? And then finally, as we get down, we will see the branching to the common iliac, going down into each leg. That's it, okay? For the abdominal arteries, that's really it. So this is back here, that is the abdominal aorta. And it is all the way from the diaphragm all the way down to where it splits into the iliac, the common iliac arteries down into each leg. Here is the celiac trunk, which is literally the little trunk here at the base of that first branch, which I don't need you to know what it branches into. Just know that the celiac trunk is right there next to the stomach. And then farther down, so here's that celiac trunk again of the abdominal aorta. Now look at these guys right here. Those are the renal arteries going into each kidney. Okay. And now we will follow it or continue down to the common iliac arteries, right and left, one for each leg. Oh, sorry. This is deep. So this is actually closer to like your spine towards the back. And then this is, I don't want to call it superficial, but it's anterior to that. This is the vasculature associated with your large intestine, as you can see. It's beautiful and complex, and I'm not asking you to know any of it right now, okay? All right, let's visit our friend over here before we get too far. All right, so we're talking about the abdominal aorta, which is anything below the diaphragm, right? So here's the diaphragm right here. You can see this umbrella shape that the blood vessels have, indicating that's where the diaphragm is, right below the heart. So below that, we've got abdominal aorta. We've got the hepatic trunk. The celiac trunk. We're talking about arteries, so I want you to know about this guy right here, celiac trunk, and the renal arteries left and right, which go to your beautiful, beautiful kidneys. Look at that. Isn't that so pretty? I just think that's so pretty. This is your spleen. How beautiful. So see your left and right kidney and the blood flow going to it. Don't worry about the rest of them. I just want you to know where they branch off from the abdominal aorta, okay? And as we continue down, we're going to now look at the common iliac arteries going down into each leg. This is just one leg, obviously, right? So the abdominal aorta, the common iliac artery. As we go down, it becomes the external, and then another one kind of branches off and becomes the internal iliac artery. We're not worried really about what happens after that to that one, but this one continues down to become the femoral artery. And then it becomes the popliteal artery as it passes behind the knee. Popliteal is the backside of the knee. And then it branches into the anterior and posterior tibial arteries, as well as the fibular artery, which is kind of goes around the posterior of the leg towards your calf there, okay? So let's take a look. Again, we've got our abdominal aorta. The common iliac artery is that first part right after it branches. Then you've got this tiny little internal iliac artery, and the rest of it we're calling the external iliac artery now. Then we follow it down until we call it the femoral artery. Don't worry about exactly where that happens. I will not ask you something questionable, okay? It's the femoral artery, like from here to here. And then once it goes behind the knee, it's the popliteal artery. Past the knee, you got another branch. One half goes anterior to the front of the tibia. The other one stays posterior behind the tibia, hence the anterior tibial artery and the posterior tibial artery. Meanwhile, at the back of the leg, see how the anterior tibial artery, this is a posterior view. So see how it goes in between the tibia and the fibula anteriorly and ends up here. The posterior tibial artery continues down, and basically it branches, and its other branch is the fibular artery because it comes around over here to the side where the fibula is. Okay, let's take a look at our friend. Common iliac artery, right? branches into the internal and external iliac artery. Not worried about where the internal goes, don't worry about it. The external iliac artery continues down to become the femoral artery. And this is the same thing that happens on the other side, right? Common iliac, interior iliac, exterior iliac, femoral. Femoral comes down to behind the knee to become the popliteal. Look at all this blood flow happening at the knee for that joint. Part of it goes anterior. It's hard to tell which one is anterior, which one is posterior here. Okay. Branches off. One goes anterior, the other branch goes here's the popliteal. Here's the anterior tibial. Here's the posterior tibial. And here's the branch that goes off to become the fibular. Okay. See how it's on the outside of the leg. Okay. That's on the outside. This is anterior tibial. This is posterior tibial. Oops. This is posterior tibial. Okay. Cool, right? So let's zip through the veins now and see how they line up. All right, so here's the same schematics for the entire systemic circuit, right? Which means that since it's all systemic, it's all low oxygen in the veins, okay? All veins. So we're talking about returning from the extremities, from those capillary beds throughout the body, returning and basically coalescing like tributaries going towards a lake, right? Going from smaller vessels to larger vessels now. So this is the opposite of what arteries do, right? Because we're on the other side of the path. We're on the other side of this systemic circuit. One circuit goes from larger to smaller down the capillaries, and now the blood is going through the veins from small venules into small veins into large veins, right? So as we look at these, just keep in mind that we are going the opposite direction of the actual blood flow, okay? I'm gonna look at the largest vessels first, just like we did for the arteries, but just remember that this is like the last thing and now we're backtracking. So the last things are the superior and inferior vena cava, right? Because the heart is here. And they are bringing blood to the heart, right? So basically the heart is the last stop. So the superior and inferior vena cava are bringing blood to the heart. As we move away from the heart, backwards against the flow of blood, we can follow the superior vena cava to brachiocephalic veins instead of a brachiocephalic trunk like on the aorta. The right brachiocephalic vein is going to become, it's going to split and become the jugular and the right subclavian vein. That subclavian vein will continue to, oh shoot, let me draw my arrows correctly. I got into a bad habit there, pardon me. Okay, so the superior vena cava is the result of the brachiocephalic branches, that it is the result of them merging, these two branches merging. Each branch is the same. So in this case, the venous system is symmetrical in the body. Okay, so you have brachiocephalic, brachiocephalic, forming the superior vena cava. From the brachiocephalic, we have our subclavian and our jugular. Okay, same thing on the other side. Subclavian and jugular. The subclavian comes from the axillary. The axillary comes from the the brachial vein, which comes from the convergence of the radial vein and the ulnar vein, okay? So they still run alongside their arteries and are very similar to the arteries, okay? Check it out. So just like we had our aorta with those three trunks coming out, right? This is the brachiocephalic trunk. Instead, with the superior vena cava and the veins, we have two branches coming off of that superior vena cava. Each one is a brachiocephalic vein. And each brachiocephalic vein comes from the convergence of the left and right jugulars, okay, which drain blood from the brain, okay? So the jugulars are coming down, joining that brachiocephalic branch on either the right or left side. Those converge to form the superior vena cava, okay? While that's happening from the jugulars, you're also receiving blood draining from the axillary vein on both the right and the left, which are coming from the brachial and basilic and I have a hard time seeing the brachial. Come on, baby. Oh, now I've done it. Really pissed it off. Calm down. Is it just really small in this illustration? Ooh, we've split them up. Okay. Now let's take a look at this actually, real quick. Before I follow this down any further. So the brachial vein in complete anatomy has been split up. So I guess technically it's two. So this is actually a little bit more advanced than we even need it to be, which is actually kind of awesome. But not necessary. Let's remove some of this. There we go. To simplify this even more. Okay. Superior vena cava, brachiocephalic veins, which are the convergence of the right and left jugulars. These guys drain the brain. Before I get too far. Do a structure that we will look at in a minute, okay? And then, like I said, we've got brachial, we've got radial and ulnar. The problem is that we have a couple of other things here too, okay? So we're gonna look at those when we get to the arm specifically. Meanwhile, let's go down to the inferior vena cava as it travels up through the diaphragm. So in the abdomen region, we have again, let's see, we have hepatic for veins, okay? So we have the hepatic veins, which are basically on the same level as, and do we even see them here? Look at it. Whew, good God. Good golly. Okay. No. Okay. We have hepatic veins, which if I can get the right arteries going here. Okay, so they're gonna be superior up here. These guys are going to be draining blood flow from the liver, which you can actually kind of tell. I'm sorry, that's not correct. From the diaphragm, not the liver. Okay, so the hepatic veins are up here. The celiac trunk is down here. But the renal veins and arteries are on a level, which makes sense, right? Because they're going to the same place. So Look at how gorgeous. It's like the vena cava and the descending aorta are dancing. Do you see it? It's like they're holding hands right here. I love it so much. So here's the renal artery, and here's the renal vein. The renal artery coming from the descending aorta, abdominal aorta specifically, and the renal vein coming from the inferior vena cava. And where they come together, it kind of looks like they're holding hands and dancing. It's kind of beautiful. I just love that. Look at how pretty. Anyway, don't mind me. We've got renal veins, we've got hepatic veins, and then we're going to skip everything else and go back down to the common iliac veins, which are in the same place as the common iliac arteries. We also have external and internal iliac veins, and we go down and become the femoral veins. I'm doing it again. My brain is starting to go. Okay, so the common iliac veins converge to form the inferior vena cava. Those common iliac veins come from the external iliac vein, which comes from the femoral vein, which comes from the popliteal vein, which comes from your tibial and fibular veins, okay? So we need to know external jugular, internal jugular, right and left brachiocephalic, superior vena cava, the hepatic veins, the renal veins, the common iliac, the internal iliac, the external iliac, the femoral, popliteal, posterior, anterior tibial veins. And on the back will be another fibular. Down the arm from that brachiocephalic trunk, we end up with a subclavian vein, which becomes an axillary vein. The cephalic, brachial, and basilic are the big difference between the venous system and the arterial system. But from there, we still have an ulnar and a radial vein, okay? I wanted to put these side by side for you. They're not side by side in your text, so here they are if you wanted to compare them directly. Let's go ahead and do this. Common, internal, external femoral, popliteal, posterior, anterior. The great and small saphenous veins will also come into play here. Basilic, brachial, cephalic, axillary, subclavian. And on the arterial side, internal, external carotids, common carotid, subclavian, brachiocephalic, aortic arch, celiac trunk, renal arteries, common iliac, internal iliac, external iliac, femoral, popliteal, anterior, posterior, tibial, and down the arms, subclavian, axillary, brachial, radial, all of them. Okay, you guys, let's continue. Here's the structure that I was talking about, where the internal and external jugular veins go up into the brain. We're going to be draining the brain here, okay? So we want to know this subclavian as it goes from the arm, and then the other branch of the superior vena cava coming from the internal jugular vein. We do have an external jugular right here, but they are both going to come up internally inside of the skull and become this, and basically drain from this superior sagittal sinus, which is this really trippy line that comes right down the center of the inside of the skull. So it's this right here. Look at that. It's really, really weird. Okay, so that is the structure that I want you to know for the venous circulation in the skull. Okay, for the arterial circulation, that's circle of Willis. For the venous circulation, it'll be the superior sagittal sinus, which comes down and feeds the internal jugular. Okay, internal jugular. Internal jugular. And that's it. And again, side by side so that you can compare side by side. And we can't really see it, but this is that superior sagittal sinus, okay? And on the arterial side, we will need to know our axillary, subclavian, going up into the common carotids, external, internal carotids, going up into the circle of Willis, okay? Okay. All right, you guys, upper limbs for veins. Here's where it gets a little bit different from the arterial portion. You still have a subclavian going into an axillary, okay? Subclavian going into axillary. But you do have 3 branches here where you would only have the subclavian and the axillary continuing down and becoming the brachial. Instead, you have a branching of the axillary into the brachial, as well as, so here's the brachial, which runs deep, but you also have the cephalic and the basilic veins on either side of the brachial vein. The cephalic and the basilic, those guys are going to go down and continue, pardon my wrong arrow again, they will continue down and become the radial and the ulnar veins, okay? So all 3 of these guys come up and become the axillary, which becomes the subclavian, which becomes the brachiocephalic, which converge to form that superior vena cava. Okay. And again, side by side. Superior vena cava is the convergence of the left and right brachiocephalic, which come from left and right subclavian. Going down the right arm, the subclavian comes from the axillary, which comes from the convergence of the brachial, cephalic, and basilic veins. The cephalic and basilic veins come directly from the radial and the ulnar veins, respectively. Okay. Cephalic comes from the radial vein, and the basilic comes from the ulnar vein. Okay. And on the arterial side, again, descending aorta, brachiocephalic trunk, which becomes the right carotid, the middle trunk becomes the left carotid, and that last trunk becomes the left subclavian. Right and left subclavian become the right or left axillary, which become the brachial, which branches into the radial and ulnar. Okay. This is going to be really great to draw out. Okay, you're going to want to draw this out. Don't look at me like that. All right. Hepatic, renals, here and here, and iliac, external and internal. And again, hepatic, These are going to be draining from the diaphragm, the renal, draining the kidneys. This is the inferior vena cava, of course. It is the convergence of the right and left common iliac vein, which is the convergence of the external and internal iliac veins. This portion is deep, so it's way back towards your spine. This is anterior to that and how your blood flow from your large intestine and stomach is drained, but I don't need you to know any of that, okay? And side by side, hepatic are up here, renal are down here, inferior vena cava, external and internal and common iliac, compared to arterial, which includes the celiac trunk, renal arteries, abdominal aorta, and the common iliac artery, which branches into the exterior and interior iliac arteries. All right, I'm gonna have to make a separate thing of these slides, huh? And in case you're interested about the more, this large intestine vasculature. Your pelvis and lower limbs, so getting down into the legs, okay? So we already talked about those. Common iliac veins, which go down one for each leg and are the convergence of the internal and the external. And they, I should say that that external one comes from the femoral vein, which comes from the popliteal vein, popliteal, I should say. And then we have a little bit of complexity going on here, but it's not as bad as the arm. We do have anterior and posterior tibial veins, but we also have this other system going on at the same time. It's the saphenous veins. So these guys are kind of running along the inside of the legs. And up towards the femoral vein, we call it the great saphenous vein, and then it gets smaller as it goes past down the knee. And at that point, we call it the small saphenous vein. That's how I want you to know this. Okay, so the great saphenous vein, the small saphenous vein comes up around the outside. Let's look at this. Common iliac, internal iliac, external iliac, which comes from the femoral, which comes from the popliteal, which comes from the combination of the small saphenous, the fibular, and the anterior and posterior tibial veins. Where's your posterior? There you are. Okay, let's explore this real quick here. Okay, coming down. Is this a male or a female? How can you tell? Right? Oops. Okay. Let's get rid of our arteries. We're just talking about veins here, really. All right, so common iliac coming from the external and the internal. Coming from the external comes from the femoral. Same on both sides, okay? The femoral is going to be contributed to by this great saphenous vein. This great saphenous vein is on the it's like very superficial, so it's near the skin. So if we're going to be doing like a bypass surgery on the heart and we need a little piece of a vein to replace a blocked part near your heart, this vein is one that's commonly used. Saphenous also means obvious. So it's the obvious vein to use in case of like needing a piece of vasculature from elsewhere in the body in order to do a bypass surgery on the heart. Kind of cool, right? So that's the greater saphenous vein. Meanwhile, the femoral vein is becoming the popliteal vein. And that popliteal vein, which goes around, again, the back of the knee, is going to be contributed to by the small saphenous veins. So let's see, the large saphenous, the great saphenous is here, anterior and medial. The small saphenous vein is going to be posterior, really just posterior here, okay? So you have small saphenous, you have your popliteal, great saphenous. The popliteal is going to branch down here into the ones that we are familiar with from the arterial, right? Which is going to be your anterior tibial. Here's the popliteal. You have your anterior tibial, fibular, which is going to go off to the lateral side, and your posterior tibial vein, okay? Anterior, posterior, fibular. Okay, popliteal, posterior, anterior, and fibular, which should be lateral because it's going down the side of the fibula, right? Okay. Okay. And here again, they are side by side. You need your common, internal, external, femoral, great saphenous, which again is superficial. Your anterior and posterior tibial veins, your fibular vein, and your small saphenous. There's popliteal, small saphenous, fibular, anterior tibial. And on the arterial side, we've got the common iliac, internal iliac, external iliac, femoral, popliteal, anterior, posterior tibial, and fibular. All right, you guys. Development and age, let's wrap it up. I'm going to make sure that these slides are available for you in a separate PowerPoint that hopefully will be easier to download. I'll add that to our to-do list for this week. Marked slides. All right, so we have some differences between before birth and after birth in terms of the vasculature. At birth, the umbilical vessels need to be blocked off, right? So we're not using the umbilical cord for nutrients and oxygen anymore, so that needs to be blocked off, which means that we have some leftover structures here, which is kind of interesting. If I bring up enough of this, you can actually see these guys right here. The medial umbilical ligament is all that's left of the umbilicus, which is kind of trippy, right? You also have these shunts or these holes in the septum and the ventricular and the atrial septums of the heart because you're not using the lungs. So the blood kind of just goes round and round the systemic circuit and ignores the pulmonary circuit until after you're born. So these different vessels and shunts, the foramen ovale is the technical term for that hole in the ventricular septum, are blocked, right, as they should be, and the blood flow is rerouted. A newborn's blood pressure is relatively low, or what we would consider to be low, 90/55. As you get older, your blood vessels get longer and they get, well, they get longer. And as we know, the longer the vessel is, the more resistance it provides. So pressure increases in the vessels. The adult normal blood pressure is 120/80. As you get older, of course, your venous valves are going to weaken, leading to varicose veins. But that's not really that bad of a thing. Worse is tingling and numbness in the extremities, indicating poor circulation. And then the worst of all that can happen is atherosclerosis, which is a buildup of plaque, and it's actually a roughness on the inside of the vessels from injury, from stuff rubbing against it, from bad cholesterol catching on it. And then you basically have more and more epithelial cells kind of like catching on it. And eventually that vessel can be blocked. Depending on where it's going, it can cause tissue damage. Obviously, the tissues that are no longer receiving blood are going to be very damaged. If this happens in the brain, we call it a stroke. If it happens to the blood vessels that actually serve the heart muscle itself, so the carotid veins and the cardiac, or the carotid arteries and the cardiac veins, causes an infarction, which is a heart attack, right? The heart muscle itself doesn't receive blood, which is so sad and ironic since it's still pumping blood. The blood is right there, but it's not getting it itself, and heart cells die. Atherosclerosis is more of a problem for men than women throughout life because there are protective effects of estrogen for women. After the age of 65, the danger evens out for both men and women, and then they are both equally susceptible to heart attack or stroke. And that's it, you guys. I hope you enjoyed this very long lecture. I'm sorry that it took so long. I really did enjoy using our little complete anatomy friend here. I do again recommend that you invest in this. I think it's a great idea to invest in this for studying. And I will add those slides to our to-do list under additional resources. Make sure that you prepare yourself before lab on Thursday, okay? I want you to try to take as much of that time as possible to identify as many of the vessels as you can. I have a list in the lab description of the vessels that you need to know. So not only will you have the PowerPoints with the different ones underlined, but I have all of those underlined names in a list right here. And I have them indented according to the branching of them, okay? So it looks like a lot here. I know it looks very scary. But we talked about all of them. We talked about all of them here, and their names correspond to where they are, right? Axillary is armpit. Brachial is like where the brachial muscle is. Radial and ulnar. Your femoral going down into the legs, the femoral to the popliteal behind the knee, tibial and fibular, anterior, posterior. A lot of this stuff is pretty intuitive if you know your terminology for the regions of the body and the names of the bones and stuff that we learned in part A, right? Here's a PDF of all of these names. So you can literally just print out this PDF or bring this PDF and check them off. I recommend that you do this on Thursday, okay? So make sure that you go into the description of our lab for this week. Watch the videos on the dissection of the vessels of the thorax and the abdomen and a couple of different quadrupedal mammals, although maybe not rabbits. It'll be similar enough. And another good reason to make yourself very familiar with this right now is because it might look a little bit different. Okay, so make sure that you are familiar, and you can look over these as well for what veins and arteries look like in different systems, in different species even, okay? Slideshows, quizzes, practicals you can make out of this. Okay, you make flashcards out of these. So use them. Be prepared before lab. That's what I ask. All right, you guys. Thank you again for staying so long. Thank you for watching. And I will see you on Thursday. Have a good rest of your week. Bye-bye.